Good evening, everyone. Thank you for joining us. My name is Elias Kalanzas with Transform Dental Sleep. I've got with us tonight Dr. Jagdeep Bijwadia, MD, MBA, and a good friend. We're going to be discussing vaping, mouth taping, CBD, and herbal and sleep science or a seedy scam. Before I ask Dr. Jagdeep to just give us a quick bio, I just want to do a quick housekeeping. If you're interested in your CE certificate, at the end of this webinar, you will be asked a series. I think there's a couple questions on there. Those questions will pop up after you close out the webinar, and then you'll be receiving your CE certificate within 48 hours. Number two, if you have questions throughout tonight, please feel free to use the Q&A, the question and answer tab at the bottom of the screen, or chat. I will make all chat live, so you can ask questions to either myself or Dr. Jagdeep throughout tonight. So we will, if I find that the question pertains to where he is at in the slides, I'll ask the question at that point. If not, we'll hold it till the end. There'll be a 10-minute right at 7:50 Central Time. There'll be a Q&A time. So if anybody has any questions, feel free to throw that out to us. So Dr. Jagdeep, before we get into the slides, can you just give us like a 30 to 60-second overview of who you are, why you're great?
Yeah, put me on the spot right away. I love it. Thanks, Elias. Always fun to be here. Love working with you and Jason, and it's a privilege to be talking on this webinar. So I am a pulmonary and sleep medicine physician. Been in practice, more than years than I'll admit here. But have been was at the University of Minnesota running their sleep medicine program for many years. Have done a lot of sort of business development, telehealth things, and most recently, and chief medical officer of a tech company called Happy Health. So, been involved with sleep for greater than 20 years. I remember reading paper polysomnography a long time ago. So yeah, it's a privilege to be talking here today. Appreciate it.
Awesome. Well, definitely thanks for having us. And I should say for everyone is Dr. Jagdeep was going to be at the 2025 Transform Dental Sleep Symposium that we're having in 2 weeks here. Unfortunately, he had something more fun that popped up that his schedule would not allow. And we had several people reach out because they were excited about this topic. And he actually was kind enough to say, hey, I don't mind sharing this lecture with everybody. Let's just do a webinar beforehand. So that was the impetus of tonight's webinar. It's because he's not going to be able to come to the symposium. He's going to give that presentation tonight, but we will most certainly have him on the dais next year, 2026, with a different topic. So just wanted to throw that out there. So without further delay, let's dive right in. Dr. Jagdeep.
Thank you. So, if I had to summarize and put all of my slides in a nutshell, I thought this cartoon sort of summed it up pretty well. This is the owner and founder of a chocolate company, and he says, "Look, half the work is done. All you need to do is fill in the top part," which of course is the data. And I think it's emblematic of a lot of things we'll be talking about because there are many approaches to sleep, as everybody knows. There's lots of different options and treatments out there. Some of them better supported by evidence than others. But I think for us, what I'd like to do is dive in a little bit into a few of the topics, especially CBD, marijuana, things like that, and talk about, what is the evidence out there? We know that there's a lot of interest. I had a patient, just last week, she said, "Look, I've been using marijuana for my sleep for the last 5 years, and I really want to get off, and I stopped it, and my sleep just fell apart. So what do you want me to do?" And so how do you answer somebody like that? Should they go back? Should they try something else? Where does the evidence lead us to this? So let's start with the next slide. Thought it would be good to start with just a little bit of basic physiology. So the cannabis plant, Cannabis sativus, is something that, of course, has been known for, thousands of years. And In ancient literature in India, there's been, talk about using cannabis for various ailments, pain, depression, anxiety, things like that. Queen Elizabeth the First used it for menstrual pain. So we know that, there's medicinal properties. But it was only in the early 1990s that they actually extracted the molecule or the chemical in the plant. And it's called delta 9 tetrahydrocannabis. And the interesting thing is that it has a affinity for a naturally occurring receptor in the brain and other parts of the body, and called the endocannabinoid system. And CBD is another molecule also, extracted from the plant. In fact, there's hundreds of different chemicals in this plant. But it just so turns out, as biology has it sometimes, that this one particular chemical, delta 9 THC, fits perfectly into the endocannabinoid receptor model. Just like, morphine from the poppy seed can fit into our opioid receptor, similar to that. And there's other examples in biology and human receptors that you can point to. But endocannabinoids are, just go back to the initial slide, endocannabinoids are sort of the human equivalent or are natural chemicals that are able to interact with these receptors. And when they interact with these receptors, a large number of sort of physiological responses occur. So the two endogenous or endocannabinoids are 2-AG or 2-arachidonic glycerol. And then there's AEA or anandamide. So those are the two intrinsically available compounds that we have in our bodies. Next slide. So these endocannabinoids and THC have like remarkably diverse effects. These are just, effects on the brain. So they are involved in synaptic plasticity, synaptic pruning, pain reception, stress and emotions, learning memory. In fact, if you look at the receptors for these compounds, they're concentrated in the amygdala, hippocampus, and parts of the cortex. So a wide range of functions, even in the brain. And if you think about what endocannabinoids do, think of the chemicals as trying to maintain the body's stable state or homeostatic state. So for example, if there are external stimuli like, stress or pain or hunger, it results in bodily release of certain hormones. So a good example would be cortisol. If you go to the next slide, if you look at the example of stress releasing adrenaline and then, causing a surge in the cortisol levels, what endocannabinoids do is they temper that response. So over time, the endocannabinoids allow less and less and less cortisol to be released with stress. And so it's a coping mechanism long-term for stress. And that is just one example of an external stimulus. But it could be an emotional stimulus. It could be pain. We know that endocannabinoids and THC are helpful in relieving pain, for example. But that's how these chemicals really interact biologically within our system. Next slide. So when you think of endocannabinoids, there are actually two types of receptors that they interact with. The CB1 receptors are concentrated mainly in the brain, like I pointed out, the amygdala, the hippocampus, those areas. And they're involved in, memory, pain perception, short-term memory, working memory consolidation, things like that. While CB2 receptors are more widely spread, and they are in, several different organs in the body, but also concentrated more in the peripheral nervous system and in the immune cells. So we think that CBD2 is mostly involved in immune modulation and inflammation and modulating those effects in the body. And this is important because when we think about THC and CBD and all of these, we need to know, well, which receptors are we talking about?
Sure.
Next slide. This is a very busy slide, so I won't go into it too much, but I wanted to point out that there are some unique features of these endocannabinoids. One is that they are synthesized from lipids in the postsynaptic neuron, unlike most receptors that are or chemicals that are released from the presynaptic. The second thing is that they have a down regulatory effect. So what they do is they sort of tamper down release of certain chemicals, for example, adrenaline or catecholamines, and try to sort of, again, maintain homeostasis. And lastly, they can control their own release. So they are what we call self-regulating, or they can down-regulate their own production. So those are some unique features, and that's important because if you look at the next slide, um, you know, um, because there's various types of chemicals that we're going to be talking about. THC, by the way, is a Schedule 1 controlled substance. So
For now.
despite its federal, for now,
For now.
uh, yes, and despite the federal classification, as you know, more than 40 states have basically legalized marijuana, right? Um, Now, when we talk about CBD, that's different because it doesn't have any of the psychological effects or neurostimulating effects that THC does. So it was legalized. So the 2018 Farm Bill, for example, legalized hemp, which is a type of CBD. And also marijuana-derived CBD is also legal if it contains less than a certain percentage of THC. So the regulatory and the legal sort of environment for these drugs is a little bit complex. And it's not as easy as saying, well, you can take marijuana. It depends on what state you're in, whether you're violating federal rules. So I think we all need to be aware of these sort of, I'll say, limitations. Next slide. So one of the beauties of nature, I think, is that it has extreme specificity, right? So when you're, for example, when you have stress and you're releasing endocannabinoids, those endocannabinoids have very specific receptor-related actions to cause reducing the stress, right? To reduce stress. THC, remember, attaches to the same receptor, right, as an endocannabinoid, but it's not as specific. So its actions now sort of spill out into the memory, cognition, motivation, appetite. So we all know that when you take THC, you feel, a little bit of those hunger pangs, or you might get a happy high, or you might even get anxious and paranoid. And it's important to recognize that even though THC binds to the same receptor as the endocannabinoid, it doesn't have the same specificity. And that is why there's all these varied effects when you use these substances. So next slide. All right. So what are the risks of THC in general? I think we worry about the fact that you can get psychosis, anxiety, and paranoia, sometimes cognitive impairments and memory and attention deficits. Physical health risks are fairly rare, but there have been descriptions of respiratory issues and cardiovascular effects with these. I think more important is things like cannabis hyperemesis syndrome. You should be aware of this. So if somebody starts themselves on marijuana for, let's say, sleep or pain or something, sometimes they can get copious and really disabling vomiting, and you should make sure that you know that those could be related. And of course, when you use THC, oftentimes the initial dose starts sort of being escalated over time. So there are concerns with habituation and potency. Next slide.
Yeah, I have to say, this is the first time I've ever thrown out a question and no one's answered. And it was, have you tried CBD or THC to assist with your sleep? I
Yeah,
should say your sleep in there, and nobody wants to answer. It's kind of
yeah,
a topic,
yeah,
but I do want to circle back to cardiovascular effects and respiratory issues because a lot of people, there's also gummies as well that
Mhm.
don't affect that. But we'll circle back. Keep going.
Yep. All right. Yeah, we can get back into that. So now, some of these synthetic cannabinoids do have approved uses as well as THC. So, dronabinol, for example, is used for nausea and vomiting, especially in chemotherapy-related areas. Interestingly, there was a very provocative article, I would say about a couple of years ago, about using dronabinol for obstructive sleep apnea.
Mhm.
And anyway, we will not digress too much into that. But there are some approved uses. So, for example, it is used as an appetite stimulant, and dronabinol is, and especially in patients with HIV. So we know that those are effective, and in chronic pain as well. CBD specifically has a synthetic formulations like Epidiolex, which is used for certain rare forms of seizure disorder. PTSD, and anxiety. So there are synthetic analogs of these endocannabinoids that are available commercially today, FDA approved, for management of these conditions. But I think, with this audience, what I'd like to do is sort of now sort of focus in and, hone down a little bit more on, what about sleep? What are the effects of these substances on sleep, and should we be using them for our patients? So next slide. So I think, going back to our first slide we started with, it's all about the data, right? I mean, how reliable is the data? And the problem is that although there are studies, they usually involve pretty small numbers of patients, usually typically 10 or 20 patients. They have heterogeneous study design, so they often are not blinded, or they're not placebo controlled, for example. They're usually short term, so they have maybe for a few weeks at the most. A very significant issue is dosing. You can have different dosing for these substances. Sometimes there's smoke, there's vape, there's gummies, there's all kinds of different ways of delivering these medications. And there's no FDA control of how much of substances in each one of those. So we don't really know what the strength of chemical the patient is getting. There's a lot of individual variability in response, so it's not very uniform. And sleep is often studied as a secondary outcome. So you might be studying THC for, I don't know, chronic pain, and then you have sleep as a secondary study parameter. And so there's not many studies that have looked at sleep as the primary objective. All right. And then lastly, objective measures of sleep are often lacking because you can't do polysomnography repeatedly. Home sleep testing, maybe some studies have used, but there's often lacking of the objective measures. So I'll just go through very few studies that I picked out just because I thought it was interesting. One is the effects of THC on sleep, which was just a systematic review that was done in 2023. And ultimately, they said that, look, THC does reduce the sleep onset latency. So it is true that you can shorten the time to fall asleep. But short-term use actually may increase slow wave sleep. There's very few substances or medications even that increase slow wave sleep, but that's true. But unfortunately, it also reduces REM sleep. And so we don't know really what the impact on the person's sleep might be when you increase delta and reduce REM. We haven't had great data about the importance of each stage of sleep. Next slide. CBD, it's important to note that the effects on sleep are often dose dependent. So if you use lower doses of CBD, it can sometimes increase the wakefulness and alertness, while higher doses might improve the total sleep time and have reduced nighttime arousals. And that's been shown in this particular study, again, very recent in 23. Next slide. So what about the long-term effects of cannabis use? Are there any issues? I think there is some data to show that long-term THC use does increase dependency and withdrawal symptoms. So the patient that I talked about early on, it's possible that, although she was well controlled for 5 years, now that she's taking away her THC, you get these withdrawal symptoms. So this dependency may not be sort of physiologic. You're not getting all the physical symptoms of withdrawal, but in terms of sleep, at least, you can disrupt your sleep when you remove the THC, and can cause vivid dreams and restlessness as well as insomnia. Next slide. So I think, it's safe to say that the effects of marijuana on sleep aren't simple. It's fairly diverse and complex, just because it has so many actions throughout the brain system. And it depends on so many factors, like how often do you use it, what dosing are you using, what is your individual genetic, response to THC. But it does seem to help with sleep onset. And, just remember that if you use it chronically, you might have some sleep disturbances, especially when you take away the THC and have rebound in insomnia. Now, CBD, similar to THC, of course, the advantage is that it doesn't have any of the psychotropic effects. So you have a fairly pure reduction in sleep latency. It also seems to affect REM sleep less than THC. We don't know whether it increases delta sleep. There's not a great amount of data on CBD and deep sleep. But given that they're related to THC, it might be so. One good thing about CBD is it is an anxiolytic and also pain reducer. So I think that CBD probably has a place um, in treatment of sleep, especially in patients that are mildly anxious or have some sort of pain-related insomnia issues. CBD might be worth a try. And of course, the biggest advantage is that we don't have any dependency issues with CBD.
With CBD. Got it.
Yeah.
Uh,
Of course, the problem still is that, the formulations of CBD in the market are not FDA controlled, so you don't quite know
yeah,
what dosage you're giving the patient. Even though the bottle might say 2 milligrams or 5 milligrams, we're not really sure oftentimes. Next slide. So my bias is that if you are going to use CBD or even THC, if the patient says that they're going to use it, start with a lower dose. Don't go to a high dose right away. um, Monitor their sleep. I think that's a key takeaway. In fact, any intervention you do in sleep, if you have a way to monitor whether they're sleeping better, less arousal, sleeping longer, latency, anything you can do objectively to monitor them is going to allow you to tailor your therapy better. And then, of course, be aware of potential drug interactions for whatever you use. And in general, I would say that if a patient has, even chronic liver, kidney disease, if they have, certainly neurologic issues, pregnancy, breastfeeding, generally, I definitely like to stay away from them. I should point out the American Academy of Sleep Medicine does not endorse the use of THC or CBD or cannabis derived substances for the treatment of sleep apnea,
Shock.
mainly due to lack of the scientific evidence and supporting evidence of safety and efficacy. So I'm sure I should be careful to point that out.
Absolutely.
So, important to know that.
I do have a question. So let's take some people don't want to have any smoke in their lungs. They don't want to smoke anything, right? So let's take gummies for example. Um, you can get different batches of gummies, and then you can get different. You can get there's sativa,
Sure.
there's indica, and then there's also what's called, as you know, a hybrid. Okay,
Yes.
that's let's put that category on the side. So there's different types of THC, and then the other side here is um, if you take the same amount, let's say you take 10 milligrams here of, let's say, sativa, and then on the second part of this question is also it has to do with what you ate and when you ate it, and is it able to bind to
Yeah.
something, right? So if you eat it on an empty stomach, so it will vary. But my specific question is, is there any research on the differences between how sativa versus uh um let's
Right.
say indica or
Right.
a hybrid, does it affect different parts of your sleep? Does it, because what I'm really looking for is, asking for a friend. What what if
Wink, wink, huh?
which type of THC gummy affects your REM sleep the least out of the THC?
Okay, so I can tell you pretty definitively that there's very little to no data. So
Okay.
most of it is going to be anecdotal.
Okay.
I think my biggest concern is that when you say that, for example, is sativa more alerting than indica, right? So, some are alerting, some are sedating. If you go to these stores, they'll often tell you that.
Mhm.
But number one, we don't know the how much sativa or indica is in a particular formulation. We don't know what the dosage is because there's absolutely no FDA control,
Mhm.
right? So I would say that, it's sort of an experiment of N of one. Every time you take a gummy, you're basically starting over, and you know what your individual response is to that particular formulation that you bought in the particular place. And that's as far as you can go in terms of really an evidence-based approach. So I don't know that I can make any generalized statement because
So
of
you don't
that.
know any difference between a sativa and an indica in terms of how it affects your sleep?
Not data-driven differences, no. Not data-driven. Yeah.
Got it. Okay. It'd be interesting to have someone monitor their sleep every night and see the differences, I would say.
Yeah, absolutely. Yep.
Great.
All right. So next slide. So
Oh,
over to you.
already on a break. All right, we're gonna take just a quick 60-second break here and talk about the 2025 Transformed Dental Sleep Symposium. I mentioned at the beginning, Dr. Jagdeep will not be able to join us this year. However, we have 20 other great lecturers, speakers some industry giants and some people you've never heard of. We're excited about Hella Sibade. He's our keynote speaker. It's going to be from January 31st to February 1st in Scottsdale, Arizona. I see a lot of the names who are in our who are participating today who will be there. We're going to have three separate workshops the day before on that Thursday, January 30th. So check out our website. I'll put the link in the chat box to tdssymposium.com. It'll be a 2-day event. Our first one was last year in February. We had about 350 people come. I think we're going to have about 50 more, maybe 75 more people. So we should be approximately 400 to 425 total people. It's going to be a day and a half. It's not your traditional meeting. When I say traditional meeting, it's not full of clinical science data. If that's what you're looking for, I'm sure the AADSM is for you. This is a lot more lighthearted, a lot of industry camaraderie, but great topics that you can apply in your practice. There'll be medical billing. They will be sleep testing. We're going to talk about everything from, we've got where's he at? Dr. Ryan Seuss and Dr. Nicole Chenet are going to do a great lecture on Inspire and how she works with ENTs. We got some physicians in there, Dr. Jameson Spencer. There's a lot of great lecturing topics. So check us out. And if you're available in a couple weeks, come join us in Scottsdale. So there is my 90-second. We'll just jump right back into these slides. I'll put that link in just momentarily.
Great. All right.
Mouth
So
taping.
let's turn to something I'd say less complex, but probably as controversial, which is mouth taping and the myth and reality. So let's go to the next slide. So first of all, obviously nasal breathing is physiologically beneficial. I think there's no argument about that, right? The anatomy of the nose has obviously the air that's coming in gets filtered with the turbinates. There's humidification and warming of the air that allows better flow into the lungs. The sinuses are a pretty significant source of nitric oxide. So when you inhale through your nose, there's a higher percentage of nitric oxide that you're inhaling. Because of the anatomy of the nose and the turbinates, when the air is flowing in, there's it swirls around and it doesn't go as a linear airflow like you are with your mouth. So there's a slowing of the airflow that actually promotes diaphragmatic and more physiologic breathing. There is some evidence that when you breathe through your nose continuously, you are activating the parasympathetic system more. And there's also evidence that when you breathe through your nose, especially with closed lips, it does assist in the correct positioning of the tongue and lips. I think that as dentists, you probably all are aware that in this day and age, with all of our crowded sort of maxillas and mandibles, you often have a very high arched palate, and that sort of scrunches down the nasal septum that becomes deviated. And so that there are significant reasons why nasal breathing might be physiologically beneficial. So I just want to start out by acknowledging that, right? So it is a ancient practice of pranayama, and yoga has always sort of talked about nasal breathing as important. Next slide. So we also know that chronic mouth breathing is probably not is not a good thing, right? It again introduces unfiltered air into the lungs, promotes an inefficient breathing pattern with overbreathing, especially in the upper chest wall area. There's a greater incidence of snoring and OSA because you're rapidly breathing air in and out, causing increased vibrations. It can, open mouth can cause bad breath and dental decay and gum disease. I think, Elias, when we were talking before the conference, you were telling me how one of your colleagues, had never heard that, you can get gum disease or, a dry mouth or bad breath because of mouth breathing. But it is true.
Yeah, if I can
Mhm.
quickly share that story because I think it's pretty
Sure.
impactful. It's actually Dr. Sharon Keenan. She ran the School of Sleep Medicine adjacent to Stanford for over 30 years. And I heard about mouth taping probably 10 or 12 years ago from our friends over at the AAPMD. And she found out about it and she started taping her mouth. This is probably 6 or 7 years ago. And when she went back to her hygienist accused her of cheating on her, meaning that she was taping her mouth and she noticed a great increase in her oral health. She was pretty stunned when she realized that. So it's pretty profound. Now, not obviously not every case is going to be like that, but there's multiple benefits that she saw.
Right.
Yeah.
Yeah. So mouth breathing also, results in narrowing of the dental arch, crowded and crooked teeth, open bite, dysfunction of the muscles in jaws and lips. So nasal breathing, good. Oral breathing, bad. I think that's a fair statement. Next slide. Um, but what about mouth taping? Does it work? And is it a good thing? Going back, so we know that there's a lot of hype around mouth taping, right? So I think TikTok had 40 million people signed up for what's called the mouth taping challenge. And there was all kinds of claims that what mouth if you tape your mouth, you can uh, you know change your facial structure and your nasal angle and all kinds of things. Celebrities like Gwyneth Paltrow sort of swore and said that's the best thing she'd ever done for her health. Of course, if Gwyneth said it's right, it must be right. And then there's obviously very, very influential authors and books. This is Breath is by James Nestor, who's a journalist who did a fairly extensive amount of research at Stanford and other places when he wrote the book, and really, really sort of pounded on how important nasal breathing is. Next paragraph, next slide, rather. So I think, though, I think it's important after all of that to take a step back, right, and say that, well, which one of these claims are actually true? Does it improve sleep, and is it useful for sleep apnea? Should I be using it when I have a patient that comes in with snoring? Does it reduce stress and anxiety, for example, or enhance jawline? And as odd as these claims sound, some of them do have some significant evidence. So let's sort of, again, just like we did with CBD, focus back on sleep here. So next slide. So we're going to ask the question, does mouth taping improve sleep quality, right? Does it improve snoring and sleep apnea? And then are there any practical issues or tips that we can think about when we prescribe or ask our patients to use mouth taping? So let's take a little bit of a deeper and more critical look at the evidence here. So I did a pretty extensive PubMed search about mouth taping and plugged in, like what does it do to REM sleep, delta sleep? What does it do to sleep latency? What does it do to daytime symptoms, Epworth scores? And pretty much the response I got was your search was processed without automatic term mapping because it retrieved zero results. And that was pretty amazing to me because there are so many claims out there about how mouth taping dramatically improves sleep. But again, the data is very sparse. There is one article that I found that talked about the effect of mouth taping on if a patient's on bilev and has a mouth leak. And in that circumstance, it does work. So obviously, if a patient is on BiPAP or CPAP and is having a mouth leak, it certainly does improve the sleep architecture as well. So next slide. Um, what about the impact of mouth breathing with sleep apnea? And this, I think, is a very interesting study. Again, admittedly, only 13 patients. But this was a well-done study, and looks like for every patient, the AHI did improve when they did mouth taping when patients had mild sleep apnea. You can see that the overall AHI or the median AHI was 8.4, and it went down to under 5, and the oxygen nadir improved as well, so from 82.5 to 87. So at least in this cohort of patients, it did look like when you mouth tape patients with very mild sleep apnea, it does seem to improve their AHIs. Next paragraph.
It's very interesting, by the way.
Mhm.
That's pretty fascinating.
Yep. Next. So here is a one that I thought was very relevant to probably this audience, which is that if a patient has an oral appliance and you have a high residual AHI, and then you tape their mouth, you get progressive improvements in their AHI. So here's a very interesting study from Labarca, which was at the Harvard school, where they looked at the baselines with patients with really what was moderate sleep apnea, 24.3 median. And with the mandibular advancement devices, the AHI improved more than 50%, down to 10.5. But then if you taped their mouth, they actually had an incremental improvement down further, down to 5.6. So I certainly think that this is a study that, again, not that many patients. I think there were maybe a couple of dozen patients in the study, but I think it was extremely well done. And I certainly think that this is something that I have started doing for my patients if they come in with, maybe symptomatic improvement. There's mild increases in AHI. They don't want to, have any further advancement. Certainly, mouth taping seems to be a reasonable thing to try. Next slide.
That's pretty interesting as well because
Mhm.
the AHI would reduce less without the appliance. It seems to be what is it, about 40% reduction with MAD, right?
Yeah.
That's interesting.
Yeah. So one thing I probably should point out, though, and this again a busy graph, but I wanted to just point out a couple of things. So AMT means basically an adhesive mouthpiece, right? That's what AMT stands for. And MAD is obviously, mandibular advancement device. So these were the four groups of patients,
Excuse
and
me,
you can
one more time. AMT is what is the
it's adhesive mouthpiece therapy.
adhesive? Oh yeah, I just missed that. Got it.
Yeah, it's just a mouth taping,
Yeah,
basically.
yep, got it.
Yep.
Sorry.
So you can see like towards the top, you can see some patients, for example, the patient with an AHI of 21 or the patient with an AHI of 40. When they did mouth taping, their AHI actually worsened, right? And I think that's something that we should be aware of, that at least in an anecdotal patient, you might actually see worsening of the AHI in patients when you mouth tape them. Not commonly, the vast majority did have improvements. But again, something to just be aware of in this particular study. Next slide. So very recently, 2024 October, there was a study in JAMA, American Medical Association, obviously a very influential journal with a very high readership rate. And they cautioned against mouth taping for patients with sleep apnea based on a trial of 54 patients with obstructive sleep apnea. And what they did was they measured airflow velocity and the balance of nasal versus oral breathing in these patients. So if a patient had uh, breathed through uh, breathed through their mouth and had severe obstruction at the soft palate, then mouth closure actually tended to worsen their airflow and AHI. So I think it's important. This might explain the phenomenon we saw in the previous study. So
Mhm.
if a patient is a predominant mouth breather and has moderate or severe disease, that might be a cohort that we're sort of extra careful in, something to keep in mind.
Mhm.
Next
Yeah,
slide.
obviously makes total sense.
Mhm. Okay, so what about a practical approach to mouth taping? I think that I think we need to acknowledge that while mouth taping may be subjectively beneficial, evidence base is lacking. So we don't really have great studies to show that sleep architecture or quality improves. Mouth taping should always be lightly applied. So I mean, one of the concerns is that in the middle of the night, if the patient coughs or vomits or something, what would happen? Well, the way they recommend tape to be applied is a very small piece of tape. Really, what you're trying to do is you're not trying to tape the mouth shut. That's not the idea. What you're trying to do is promote nasal breathing. So as long as you keep that in your mind, all you need to do is sort of gently put a tape across the lip, and that should be plenty. And over time, the patient can acclimatize to it. So if a patient has significant nasal congestion or turbinate enlargement or very significant structural deformities, then I think you probably should not take them. But if a patient has normal nasal anatomy, no sleep apnea, and no sleep apnea, obviously mouth taping is probably safe. Use caution in patients, like I said, with nasal congestion. Um, I think use for snoring is probably okay, as long as your nasal airway is patent. It should be fine and safe. Certainly think about it in combination of use with the oral appliances. But try not to be too cavalier about it. So moderate to severe OSA is something that we should take much more seriously. I think the concern that I want to make sure everybody sort of realizes, it's not that mouth taping itself may be dangerous, but it might mask a diagnosis. So if somebody is at home and they're snoring and they say, I'll just tape my mouth shut. Well, sure, but you could have a very significant underlying sleep apnea that is going to be undiagnosed now. And I think that to me is the major danger of mouth taping and this sort of this popular myth that mouth taping is good for everything. I actually worry about the fact that if you mouth tape without a proper diagnosis, you might not be doing the patient a favor at all. My own bias is that whenever you do any intervention, whether it's THC or medication or taping or anything, you really should be able to monitor what's happening to the patient on that particular treatment or therapy. So that I think is a critical issue. Next slide.
Can I another personal question here?
Yeah.
I'm a huge fan of, I don't know if you're familiar with like a Max Air nose cones where
Yeah.
you because I use them, I definitely use them when I exercise. How about someone who, because I have a deviated septum. Well, apparently I was a bit of a smart ass growing up and my nose has been broke a couple times.
Yeah.
So
I would have never guessed.
I've, there's a collapse over here and I actually had a deviated septum fixed about 20 years ago. But anyway,
Sure.
so one side, so I'm not asking for clinical studies, but what do you think about to promote nasal breathing? How about some nose cones and maybe some mouth?
Absolutely. Yeah. I
Yeah.
think, I think nasal cones and breathe right strips and, anything to open the nasal valves, uh,
Mhm.
perfectly fine. I think it's worth a try. Um, I just want to be sure that you're objectively monitoring the response of what you're doing, right? And as long as you're not doing it don't do it blindly. Don't do it to treat snoring and then forget about the fact that there could be an underlying issue that
Yeah,
you haven't addressed. I think that
sure,
is the more concerning part to me. Okay.
sure. I was asking for personal reasons, and I have access to different types of sleep device.
Sure. Yeah. I use nasal strips and cones all the time.
Yeah, good.
So just, I mean, we don't have that much time left, but vaping and sleep, the takeaway
Take your
here
time.
is,
Take your time. We're doing good. This is
very
great
well.
information.
Thanks. Yeah. So with vaping, I think the way most people approach vaping in my practice, and I'm a pulmonologist, maybe it's slightly skewed, is that many times they'll say, well, I know that cigarette smoking is bad for sleep and other things, so I'm going to switch to vaping. And doc, is that okay? And I think that it's important to realize that, it's not necessarily okay. And here's the reason why. So first of all, what's vaping? It's the inhalation of aerosol substances, typically nicotine in this particular uh, example. And it's very popular among young adults and smokers. And, it's perceived as a healthier option, right? Um, but there are some emerging data to show that vaping may in fact not be as safe as you think, especially for patients who have sleep disorders. So next slide. So I think one key point is that when you take nicotine and put it in a vaping device and then inhale, you actually can get higher doses of pure nicotine than you do with a cigarette. And nicotine itself, it does have some stimulant effects, right? So transitioning from a traditional cigarette to smoking may reduce nighttime coughing or things that are due to the irritation of the cigarette smoke itself. But to think that the nicotine content is going to be lower is false. Okay. Okay. Next slide. So the concerns with vaping are that number one, nicotine, of course, is a stimulant and can itself cause a sleep disturbance. So you're not really addressing the issues with nicotine when you switch to vaping. The act of vaping can and nicotine itself can have effects on circadian rhythm. We know that vaping can cause a respiratory irritation, and there is some evidence that nicotine addiction and dependency also occurs. So even though, there's this big hype about how vaping is so much safer than cigarette smoking, not necessarily true if you look at the data around vaping. Next slide.
Before we go to that next slide, I mean,
Yeah.
I feel like just straight nicotine has been over the years been bastardized and confused with obviously with cigarettes and tobacco. Have you seen any of the work coming out like an Andrew Huberman or anything he's been talking about or a Peter Attia with using just straight nicotine as a stimulant and the benefits of it? Have you looked into any of that?
Again, I mean, in looking at this presentation, I was trying to look for like data-driven things, and I didn't see a whole lot
There's
of,
there's not, right?
again, I mean, yes, I mean, there are people that, they microdoses of nicotine are alerting and sort of, can have a positive stimulant effect, appetite stimulant, all of that. But
Hmm.
if you actually do the literature search, I just hate to say it, and I don't want to sound like a broken record, but, I think we all need to be careful and be thoughtful and not be scared to use these things, but at least base our conversations with patients on what is science out there.
Hmm. Okay.
So again, vaping has been related with sleep apnea. It has a cardiovascular, nicotine certainly has a cardiovascular impact with tachyarrhythmias, we know. Um, Mental health and depression. Sorry, sleep apnea is listed twice, maybe because I'm a sleep doc. And yeah, I think I just copy pasted twice. So next slide.
Think we're all good.
Yeah. So I'm gonna spend the last few minutes just maybe self-serving, and I want to point out my bias because I just joined Happy Sleep as the CMO. But I think the reason I'm excited about the technology, and this is the ring that I'm wearing, is that it's very much like an Oura ring, nothing, very different, but it measures things like sleep latency, sleep stages, AHI, saturation, all at an FDA grade, right? So they're all it's reimbursable. It's like a home sleep test, but it's an ongoing objective monitor for your sleep, which I think is the way we should be practicing, which is why I became part of the company, because I think that our current paradigm doesn't allow us to actually manage patients longitudinally. We have one episode where we do a sleep study, or maybe 2, 3 nights, maybe at the most, and then we see them 3 months later after they're on CPAP or a dental device. But in the interim, there are so many things happening, and all we think about is, okay, what happened to their AHI month one and month three? But I think there's just a lot of data that we're missing. And this allows us to tie all of those things together. So for me, the interesting thing about any kind of continuous monitoring device, and this just happens to be one that I'm associated with, is that it allows us to take care of sleep patients in a very different way than
Hmm.
we are currently doing. So,
And it might
so
be
next slide.
interesting too if like for example, if you were, let's go back to the THC, if you were doing gummies, that if you had a sleep monitor, the first thing I thought of was if I could tell my friend, if
Uh-huh.
they have a sleep monitoring ring, they can look at the differences between, okay, you do sativa for a week at 20 milligrams, and then do the next week you do 20
Exactly.
milligrams at of indica, and then try one with hybrid. There could be some
And
because
and
because
you
ultimately
know
you want to be able to mitigate, you want to get that 25% of REM time and you don't want that going down.
exactly.
So
So
yeah.
the way I look at it is this: given the fact that there's lack of research data, what do, right? And I think what you do is you try experiments on yourself, right?
Mhm.
And because ultimately you're the end user. And so if you can actually do intervention, and it doesn't have to be THC, or it could be Inspire, it could be a dental device, it could be CPAP, it could be anything, right? Uh, you might want to know, like, hey, when I have 2 glasses of wine, what happens to my sleep? And what if I do it on a consistent basis for 2 weeks? These are the kinds of questions that you can answer so easily if you have something that gives you objective data on a regular basis. So anyway, that's a little bit about the ring. I think we've gone through this slide, so we'll go to the next.
Sure.
So yeah, so the ring, essentially we test you, we get diagnosed, sleep better, and I think it's a very seamless flow. Everything's sort of in an app, so it becomes very simple to sort of manage a patient, or for the patient to manage themselves for that matter.
Does
And it
happy
doesn't matter what treatment you're on. Again, we're completely treatment agnostic.
That's great. What
Mhm.
can Happy Sleep detect RERAs?
So the current algorithm looks at AHIs at a 3% and 4%,
Okay.
and it has a derived airflow as well, so you can look at the data along with it. And but we don't do arousal-based scoring yet, mainly because there are algorithms that you can use with the PPG technology to look at arousals.
Hmm.
But I don't think they're, robust. And more importantly, on a practical basis, Elias, there's not much value to it because none of the payers recognize it, and we don't really know what to do with RERAs, right? I mean, my thought is if you have an HI of less than 5 and you're symptomatic, you probably are going to need to try some therapy and see what happens and see if you feel better. And again, are your parameters improving? I think last slide. Yeah,
Yeah.
this is just a quick summary of a patient that I just saw, recently that was, doing perfectly well on an oral appliance. And you can see that on 12/15, she didn't wear the appliance. And all I had to do was say like, what happened that day? She said, oh yeah, that was I was traveling and I didn't have my appliance with me. And you could see his, but it's wonderful to be able to have this conversation with the patient when you're seeing them, right? And
Sure.
again, this is an oral appliance example, but it could be pretty much any type of therapy we do. So if anybody wants to try it, I think we do have a code that is in the next slide.
Oh,
Won't
great.
deliver it, but
Oh, perfect. Well, thanks for sharing about that because I'm glad you did because people are always
yeah,
asking if we get off.
yeah,
Yeah.
mhm,
So if let's see where that's at. So there's a what is that QR code?
yeah.
So if I'll leave this slide up for a few seconds. Um, I'm gonna just start. We're gonna go right into questions after this, unless you have anything else on. Do you
No,
have anything
perfect.
on Happy
This is
Sleep? Thank
great.
you for sharing that. So I'll just say this from the start. I've been doing these webinars for a decade. 95% of them, I know what the speaker's going to say. This one, I had no idea up until I saw your slides today because it's a fascinating topic. So thank you, number one. Number two, some questions. And shout out to my friend. I didn't even know you were on the webinar. Louise McDonald. I mentioned Max Air nose codes. She just asked a question. One of the things I noticed about vaping with my husband is that since e-cigarettes can be kept in your pocket, that people vape much more frequently than a regular cigarette because it's so much more convenient. What are your thoughts? That's a
That
good
is a
question.
great point. It is a great, sometimes convenience is everything, right?
Right.
And so, yeah, and thanks for bringing that up because again, the amount of nicotine is higher and you use it more frequently. So in both of those circumstances, it's a a downer.
Hmm.
Good point.
Okay. What about herbal tea to promote sleep?
Yeah. And there is some data to show that chamomile tea and some other sort of green tea derivatives uh, do have a calming effect, right? Anecdotally, I think that herbal teas, certainly cultures starting from Japan downwards, India, all of them are very into the sort of, I'll say, the tea culture. So I think if my patients ask me, should I have tea towards the evening, perfectly fine. Just be sure that there's not a lot of caffeine in that tea. So you want to be sure that it's sort of a herbal based tea and not a caffeine based tea. And then again, like not to belabor the point, but there's not a whole lot of data on any of the supplements, I would say. Maybe melatonin a little bit, but most of the supplements that you take either by tea or by, tablets, things like that, L-threonine or magnesium, all of them have anecdotal reports, but I don't know that there's widespread studies to, I would say recommend it without hesitation.
Got it.
Probably no harm though.
Yeah, I can't, probably not, right?
Yeah.
Um,
Except for the, volume. So if somebody has, an older patient, especially, when they take, fluids at night,
mhm.
especially like men with prostate enlargement, for example, that could be a downside because now, of course, you're going to wake up in the middle of the night to use the bathroom. So that could be a downside. Just be aware of that.
Got it. In the studies, do you know if the patients with severe sleep apnea, were they checked for nasal breathing abilities and obstructive congestion?
I'm sorry, could you repeat that question?
In the studies, were the patients with severe sleep apnea, were they checked for nasal breathing abilities?
Which studies were you talking about? Is there
Uh,
any one
I
that I
I don't know, Dr. Steve, if you want to just ask that follow-up question, which study were you referring to? Do you know if any of the studies were they checked for nasal?
in the materials and methods that I read, I did not see any specific mention of, examination for nasal polyps or making sure that there was good airflow.
Okay.
So it's
Um,
not something, it wasn't an exclusion criteria.
I had a doctor from Madison, Wisconsin come to me in 2016. He was all excited. He just learned about mouth taping and he wanted to start a business and he wanted me to be on the marketing and promotion side and said, let's do this, this, and this. And I'm like, hey, man, I just had a lot going on in my life and I don't know if you ever pursued it. And now there's tons of different companies and different brands and they've got sexy lip tape and all this stuff. The question is, what brand of tape do you use? Because some doctors just literally use you know, tape that's in a regular first aid kit, and some use brands that are off the shelf. What's your preference?
3M hypoallergenic tape is just fine. I don't know that any, if you're a brand person, sure, there's Mute and all of these other types of, tapes out there. Again, I just want to emphasize it back to that graph that just be aware that, certain patients, when you mouth tape, especially with more moderate or severe sleep apnea, you actually might worsen their symptoms. So just be aware of that. That was actually the first time I saw that objectively demonstrated. So it was pretty sobering.
Sure. Follow-up question by Dr. Steve. Thank you. The studies where mouth, we're getting so many questions, it just keeps popping up. Hang on. We might be here for an extra time, Jagdeep. Uh, the studies he was referring to were the mouth taping had negative effects in the study. That's the studies he's asking about. So,
Ah, I see. I see. No, in that, yeah, actually, I looked at that carefully, and they did not have any sort of nasal exam exclusion at all.
okay.
So, certainly it is a good point. And I think we all recognize that nasal congestion or nasal deformities probably are those people are not probably not going to do well with mouth tape.
Great. This is
I
apparently
think they correlated it more with the severity of the AHI.
I have the HI, sure.
And of
Uh,
course, if you looked at that graph carefully, all of those patients that had worsening with the mouth tape did do better with the MAD, which sort of is counterintuitive if it was all, a nasal issue.
it is counterintuitive, right?
Mhm. Yeah.
Um, yeah, my brain hasn't been on sleep studies in a few years. This is great.
Yeah.
This doesn't look like a question. Looks like a shout out. Next Care tape. The PA recommended it to me. It's very kind on the skin and it works. Nice. Thank you,
Okay.
doctor.
Sure.
Please discuss the danger of regurgitation and aspiration from mouth taping. My pulmonologist doesn't recommend it.
Yeah. So, it's interesting
You know,
when
those pulmonologists, they could be finicky sometimes. You know what I mean?
I don't know what it is with them. I'll just say that, when I was a fellow, and certainly early in my uh, sort of education days, everything was black or white, right? Like, okay, you can do this and can do this, right? And so mouth taping is no, because you can aspirate. As I've grown, I'll say I'll say more experience. How about I'll use that rather than older. But as I've grown more experience, I think that medicine, rather than black or white, is often shades of gray. And I think you have to sort of parse out in your own mind, based on the data that you're seeing and your own experience, where are you going to be comfortable in that gray area? Now, in theory, mouth taping, if somebody's mouth is taped shut and they vomit, right? Or they can certainly, potentially aspirate, right?
Mhm.
I have not seen reports of that, I'll say. Also, the way taping is done, it's to promote nasal breathing. It's not necessarily to seal your lips shut. That's a very important point.
Right.
So most of the time, you can open your mouth pretty easily,
Hmm.
with mouth tape. So having said that, I think I would say the common sense thing to do is don't have a big, huge piece of tape covering
Right.
your mouth that's like hard to rip off, right?
Right this way, right?
Yeah,
Right.
just a small little strip, and I don't think the aspiration risk would be high in that particular circumstance.
Hmm. Um, okay, so I know it is 8 o'clock. We're just gonna take a couple more questions here. So if you have to get off, no problem. Thanks for joining
No,
us. And
no,
you'll
I'm
have
happy to
you'll
happy to
you'll
stay on.
you'll have the questions will pop up so you can get your CE certificate. Um, any mouth taping for children?
Oh, I now there's one where I would definitely be hesitant.
Hmm.
I think their respiratory systems are probably not as robust and well developed as ours. I think there's absolutely no data in that age group. It's sort of above my pay grade. I'm not a pediatric pulmonologist. I would be I would be hesitant in that group, just because of they can certainly aspirate and vomit and things like that. Kids do that,
Of course.
and so I would be a little bit worried about that age group.
Got it. And this is our friend Rashmi Parmer, Dr. Parmer. So if
Ah, hi,
patients are
Rashmi.
not, she's great. So if patients are non-symptomatic with decrease in AHI from moderate to mild, are we using mouth taping to improve AHI parameters?
Yeah, so I would say no. In general, if a patient has mild sleep apnea but is completely asymptomatic, there's not. Let me flip it around. There's not great data that very mild sleep apnea that is asymptomatic leads to long-term adverse health outcomes like hypertension. The only one I would say probably that points in that direction to some extent is the sleep cohort study, the Wisconsin sleep cohort study, which showed that with an AHI of 5, if you follow them over 10 years, you do get, some incident hypertension. So, you know, that study aside, in my own practice, if a patient is doing well on an oral appliance, they're asymptomatic, they're not snoring, and they're not desaturating, most importantly, I don't run after a number. I look at the patient and I go clinically.
Right. I chasing that number, man. I don't know. There's probably a couple more questions we didn't cover. It is 8:03, and I want to respect your time and everyone else's. Sincerely, Jagdeep, thank you very much. This is fascinating
More than welcome.
information.
Yeah, thank
Really
you.
sorry you won't be joining us in a couple weeks, but
I'm sorry I won't be joining you. Yeah, I would have loved to be there. And yeah, you can count me in on 26.
Excellent. I was just going to say you'll be there in 26 on the dais with a different topic or a more advanced. I'm going to talk to my partner Jason on this. I think maybe we blow this out a little more as you get more research and more patients under your belt, and you're doing more with happy.
I'm hoping by next year we'll have a whole cohort of patients that have worn this ring for, months, and that would
That's what
be
I'm
that
talking
would be a
about. That's
would
exactly
be
what
a
I'm talking about.
fun way to
And by
debrief.
the way, I'm not, as you know, I'm not a clinician, but I'm gonna text you. I'm gonna get my hands on one of those rings to monitor
Okay.
myself. 'Cause I want
Sounds good.
some fun stuff. Okay. And
Sounds
then,
good.
oh, how do we get in touch with Dr. Jagdeep? Do you want me to do? Can I just put your email in there?
Sure, sure.
Yeah.
Jagdeep at happysleep.com. Sure.
Yep. Jagdeep. So I put Dr. Jagdeep's I also put your website in just a couple minutes ago, happysleep.com. So here's his
Great.
email address if you have questions. Please be kind to him because he'll probably have a lot of follow-up questions after this. So give him a
Yep.
couple extra days. And like I said, your CE certificates will be coming in the next 48 hours. Uh, Always a pleasure, my friend. Thank you so
Thank
much.
you.
I
Thank you, Elliot.
sincerely
Thanks for the
appreciate
invitation.
it.
Appreciate it.
Sincerely, thank you. And hopefully we'll see you all in a couple weeks in Scottsdale. Have a great night and thank you.